Welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Hospital and Health Management, PGDHHM, revised. MHH 102 Hospital Services. Volume 1, Block-1 Clinical Services I. Unit-4 Intensive Care Unit. 4.0 Objectives. After going through this unit, you must be able to describe the physical facilities layout, equipment, and staffing requirements in planning of intensive care unit. Measure the quality of care and take steps for improvement. Handle the challenges efficiently and thus providing a satisfactory service to the patients. 4.1 Introduction. In the previous units you have already learnt about the 3 clinical services in a hospital. In this unit there is a detailed discussion about the intensive care unit in a hospital. An intensive care unit, ICU, is a specific area of the hospital where sophisticated monitoring, titrated life support, specific therapy, and specialized nursing, at best provided for potentially salvageable, critically ill patients with life-threatening illness or injury, resulting in better patient care and ultimate outcome. It has become an important wing of critical care medicine and essential. The ICUs were developed to concentrate 3 critical components: the seriously sick patients, highly skilled staff with the knowledge. Care unit. You will also learn about the planning, staffing pattern, policies of intensive care unit, requirement of equipment and the assessment of quality of care with the steps necessary for improving the same. In the end there is also a brief discussion about the concept of cost effectiveness in intensive care services. 4.2 Definition. An intensive care unit, ICU, is a specific area of the hospital where sophisticated monitoring, titrated life support, specific therapy, and specialized nursing can best be provided for potentially salvageable, critically ill patients with life-threatening illness or injury. It is a place and not a form of treatment. It has become an important wing of critical care medicine and essential. The ICUs were developed to concentrate 3 critical components: the seriously sick patients, highly skilled staff with the knowledge. This unit, the selection of patient appropriate for intensive care, not only depends upon medical and organizational factors, but also on financial, legal, ethical, moral, and social values. Life would have been much simpler if we believed that we could characterize patients as too well, too sick, and just right for intensive care. In this connection, following simple classification can be used. A. Patients expected to survive. B. Patients potentially recoverable, a good chance of recovery. C. Patients having uncertain prognosis. D. Not likely to survive whatever is done. And A. Patients in which death is apparently imminent. In view of public expectations of what medicine can achieve, intensive care should be provided for the first 2 of these categories. However, the classification system fails to recognize that these distinctions are not always possible and not necessarily desirable. In fact, to choose appropriate patient, one must broaden the admission guidelines and include not only the too sick patients, but also those who may be too well for intensive care requiring only monitoring to prevent occurrence of serious complications. 4.2.2 Generic Goals. A qualitative basis for categorizing patients is required depending on generic goals of intensive care. The categories, which generally apply to all specialty ICU patients besides distinguishing surgical ICU patients from routine post-operative surgical patients, have been identified. The 3 categories are A. Monitoring, observations. B. Extensive nursing requirements, and C. Constant patient care. Patients are considered appropriate candidates for ICU admission for just monitoring and observation even if they are physiologically stable. This is for early detection and rapid response to serious complications. 4.2.3 Distributive Justice. Intensive care units encompass the total number of patients who could be considered eligible for care, given the number of available beds. ICU beds are expensive, and any hospital cannot afford to maintain excess of beds with available staffing to accommodate emergency admissions. Emergency admissions are predictable, although not the timing. If all the existing care has been allocated, some decision will have to be made to Distribute resources so that no patient is deprived of necessary care. In terms of ethical principle of distributive justice, the principle usually followed is first come, first served, in which the care is apportioned to appropriate candidates seeking admission, and these continue to receive care until their outcome is destined. However, it is inappropriate to devote limited ICU resources to a patient whose prognosis has resolved to one of vegetative state. In routine wards, intensive monitoring and observation was never easy or effective, as the nurse-patient ratio is usually 12:1 in night shift in regular wards in our hospitals. This means that a nurse has less than 30 minutes shift available for individual patients after excluding their time for administrative functions. The third category of patient requiring constant patient care are physiologically unstable and require constant reaction to changes and implementing, validating, and redefining therapy. There is no problem in selection of these patients for ICU. 4.2.4 Immediate Objectives, Societal Patient Values. The immediate objective for our patients and society is preservation of life and alleviation of suffering, and it epitomizes the challenge of high-tech medicine. The objective of improved utilization of ICU resources and better focus for care of patients are attainable today. Thus, diminishing unnecessary activities will decrease complications and have salutary effect. If we have more time for thinking, ordering, reacting, and intervening, we will decrease our sense of failure and fulfill important goal of caring. 4.3 Types of intensive care unit. In the modern hospitals, the spectrum of intensive care unit is wide. Due to increasing number of specialties and super specialties, separate intensive care units are being created for such newer subspecialties. Types of ICUs according to hospital categories are from I to IV. These are as under. 1. Type 1 ICUs. These can be established on regional basis, usually in category I hospitals, i.e., large comprehensive regional teaching hospitals. Ideally, they should have rounded-the-clock critical care medicine physician coverage in ICU. 2. Type 2 ICUs, full-time physician coverage within house, not in ICU, by at least senior residents, needed in Category 2 hospitals, i.e., other major teaching and community hospitals. 3. Type 3 ICUs, intensive care by specially trained nurses and respiratory therapists with strong ICU medical direction on call, are common in Category 3 hospitals. It can provide safe basic intensive care, provided there is a rational referral policy for selected problem cases. 4. Type 4 ICUs, Category IV hospitals, have no ICUs but are prepared for patient transfer with life support. 4.3.1 Classification based upon type of patient admitted. 1. Coronary Care Unit, CCU, or ICCU, for patients with myocardial infarction or cardiac arrhythmia. 2. Medical Intensive Care Unit, for critically ill cases of general medicine. 3. Surgical Intensive Care, looking after post-operative cases requiring more intensive treatment and care. 4. Intensive Care for Burn Care Unit, burn cases requiring specialized care and barrier nursing. 5. Neonatal Nursery, established near delivery rooms for care of neonates who require therapy like exchange transfusions and incubator treatment for premature infants with respiratory distress syndromes, etc. 6. Pediatric Intensive Care Unit, for treating critically ill cases of pediatric ward, e.g., meningitis, encephalitis, post-operative cases of meningocele, perforated anus and umbilical hernia. 7. Dialysis Units, Intensive Care Unit for hemodialysis and peritoneal dialysis cases. 8. Neurosurgery Intensive Care Unit, for post-operative intensive care of neurosurgery cases. 9. Renal Transplant Unit, for cases of post-operative renal transplant. 10. Cardiac Surgery, for post-operative open heart surgery cases. These are all known as unidisciplinary units run by respective departments, only requiring anesthetist help for respiratory support. But there are large number of patients who require multidisciplinary approach for treating acute conditions. They require strict supervision, additional nursing care, continuous monitoring and special care by specially qualified staff, and very often mechanical aids to support their vital functions. 4.3.2 Classification based upon organizational structure. All of the above intensive care unit can be of three types. I. Open unit. All attending physicians may admit and care for patients. However, triage decision falls on director of ICU when there is bed or staff shortage. 2. Semi-closed unit. The directors and/or associates must review and approve all admissions. However, they should take into care the appropriateness of care and staffing level. 3. Closed unit. The directors and/or associates are responsible for all admissions and discharges. Once the patient is admitted, the unit team looks after in collaboration with admitting team for efficient patient care. 4.4 Staff requirements. A. Medical staff. ICU must have a director in charge of ICU in the best interest of patients. The referring unit consultant or surgeon is neither constantly available nor he or his staff is fully experienced with specific problems of ICU patients, which are quite different from those in general wards. In UK and USA, most ICUs are in administrative charge of one or more consultant anesthesiologists with variable amount of clinical autonomy. Besides his clinical duties, in charge of ICU has other responsibilities viz. I. Spokesman for unit in administrative matters. E. Provides continuity of clinical care. E. Organizes teaching and supervision of junior staff, who require detailed instructions, not only regarding patient care but also for use of unfamiliar equipment. IV. Responsible for purchasing and servicing of ICU equipments. V. Should initiate research and be recognized as an authority. V. Should review all treatment regimen with staff. It is essential that director of ICU should be respected by colleagues, not only for his clinical and administrative abilities, but also for his tact. The sharing of responsibilities, especially for care of patients, always creates problems with disastrous results. It is, therefore, mandatory to define the terms of reference. In any case, the outline of patient's treatment is agreed in consultation with parent unit. However, staff of unit should have right to initiate and carry out other treatments which may be necessary when emergency arises. It is stated that no single physician can cover an acutely ill patient for 24 hours per day, for 5 to 6 days, the average length of stay. Some authorities are of the opinion that an attending supervisor with sole responsibility of administration should be appointed for the ICU, and he should be assisted by a resident from each of the medical, surgical, and anesthesia services, who would be on call 24 hours a day. Normally 60% of the total patients being surgical. It is necessary that a surgeon is always available in the premises of hospital ward. It is recommended by some that a minimum of 2 doctors be available round the clock. Work study conducted in some of the hospital in India has observed for ICU, 1 doctor per 5 to 6 intensive therapy beds, and out of these at least 1 resident or house physician should be available round the clock. The report of a working group on ICU appointed by the Swedish Board of Health, 1967, recommended 0.17 to 0.20 doctor per bed. In an ICU with 10 beds, this would mean a requirement of 2 to 3 physicians for a unit of 12 to 14 beds. Nursing staff. Continuous skilled medical and nursing care is essential. It can be provided only on the basis of 1 nurse per patient at all times together with an in-charge nurses. For a general ICU with a mean 75% bed occupancy, it can be achieved by 5 trained nurses per bed, along with appropriate number of in-charge nurses for day and night duties. The nurse-patient ratio, which is acceptable in ICU, is as follows. Nurse-patient ratio, 1:1/1, 2 during daytime, 1:2/1, 3 during night, 2 to 2.5 all, 1 in a 6 to 8 bedded ICU, 1 to 1.5 in a 12-bedded ICU. However, for pediatric ICU it should not be less than 1:2 every time. There should be in-service basic training program in ICU for nurses, of about 2 months, for a qualified nurse to become confident and competent. As many as student nurses as possible should spend fixed period, 3 weeks, in unit to gain experience as it is from these sources nurses can be recruited at times of need. ICU nurses are vulnerable to emotional and physical strain and therefore, postings should not be preferably for more than 1 year. However, where the establishment is adequate and the nursing staff are selected properly, trained, and supported, this is not the case. 4.5 Physical facilities, planning and designing. The ICU requires special space and equipment considerations for effective staff function. Not every hospital can provide all types of critical care. It is a service facility for its own hospital and its client. Size and design is determined by its needs. Some hospital may have small, combined unit, other may have separate, sophisticated units for highly specialized treatment. The following standards are for the more common types of critical care services which shall be appropriate to needs defined in functional program. For efficient, safe, and effective parent care, the main problem of ICU is unpredictability of demand and occupancy. In 1988, the Society of Critical Care Medicine, SCCM, developed guidelines for the design of ICU. It was suggested to have a multidisciplinary team consisting of ICU medical director, ICU nurse, chief architect, hospital administration, and operating engineers. 4.5.1 Location. Intensive care unit should be easily accessible to accident and emergency departments, operation theaters and inpatient areas. It also depends upon the architectural pattern of building, i.e., single-storied or horizontally spread hospital or multi-storied where vertical traction is applied. In single-storied hospital, ideal location should be near to the emergency service, recovery room, outpatient department and the indoor ward. However, in multi-storied building with efficient vertical traction, the ICU is recommended to be located on the top floor. This will keep the ICU away from mainstream of traffic, low cross-infection, and quiet surroundings. An important factor has to be kept in mind when choosing the proper location of ICU within the hospital, namely, the availability of space for step-down beds. Step-down beds allow for transfer of patients who needs continued monitoring or skilled care at a level less than that provided in parent ICU. Experience shows that many ICUs suffer from overcrowding and unnecessary pressure to admit more patients than they can properly care for, simply because there are no suitable hospital beds for this intermediate level of care. If step-down beds are not available, the clinicians will have the tendency to keep the patients in the ICU longer than it may otherwise be necessary, leading to overcrowding and inefficient operation. 4.5.2 Levels of provision. In the UK, 1 ICU bed for every 100 acute beds in hospital is recommended. In USA and other countries up to 4 times this proportion may be provided. In UK, units of 4 to 8 beds are rule. In Germany 5% of total number beds are for ICU. ICU of less than 4 beds and less than 200 cases annually with average occupancy of less than 75% is uneconomical. It implies that an 8-bedded ICU should admit about 500 cases per year with similar proportion in other sized units. 2% of the total hospital beds in ICU will generally meet the requirement. However, for pediatrics ICU 6% of all beds or 8% of average hospital pediatric census is recommended. 4.5.3 Special requirements. There is an average total space requirement of 50 square meter per bed. The entrance should be like an anteroom with a place for gowning and a separate emergency entrance for patients. 1. Patient's space. If it is a new construction, each patient's space, whether separate rooms, cubicles, or multiple bed space, should have a minimum 15 square feet of clear flow area and minimum head wall width of 1.2 feet per bed, exclusive of anteroom, vestibule, toilet room, locker and/or alcoves. A staff assistance system should be provided on most accessible side of bed. If private rooms or cubicles are provided, view panel to corridor are required and should have drapes or curtains which may be closed. Each patient bed area space should have space at each bedside for visitors and provision for visual privacy. There must be a minimum 8 feet distance between beds for both pediatric and adults units. Patient's bed should have visual access. other than skylights to outside environment. Therefore, there should be at least one outside window in each patient's bed area. The distance from patient bed to outside window should not exceed 50 feet. 2. Nursing calling system. There should be two-way voice communication provided, which must include provisions for an emergency code resuscitation alarm to summon assistance from outside ICU. 3. Hand washing fixtures. These must be located convenient to nursing station and patient bed areas. It is recommended that there should be at least one hand washing fixture for every 3 beds and should be located near entrance to patient room. Moreover, these should be sized to minimize splashing water on to floor. 4. Patient services. The following are essential: pipeline oxygen and suction outlets, medical quality compressed air and Entonox, 12 electric sockets, outlets for transmission of biological data to central nursing station, medical gases and suction devices, mobile partitions, bed divider system. Nursing station. This area must have space for counters, storage, and may include centers for reception and communication. The patients in ICU need to be visually observed at all times. The central station should geographically be so located that it allows for complete visual control of all patient bed. It is designed to maximize efficiency in traffic pattern. The patients should be so oriented so that they can see nurse but cannot see the other patients. 5. Lighting. The ICU should be well illuminated with non-reflecting paintworks and other surfaces. 6. Medication and nourishing areas. In ICU, provision should be there for 24 hours storage and distribution of routine drugs and emergency medication. The area should contain a work counter, cabinets, sink with hot and cold water supply, refrigerator for pharmaceuticals, and should have a minimum 50 sq feet area. 7. Isolation rooms. A. These must have a minimum 14 square meter area plus space for anteroom. Minimum 20 square feet to accommodate washing, gowning and storage. The electrical, medical gas, heating and air conditioning should support the needs of patients and ICU team members. The following additional service space should also be available within ICU and may be shared by more than one ICU, provided direct access is available. B. Securable cabinet compartment for personal effects of personnel in ICU. C. Clean supply room. It is used for preparing patient care items. It must have work counter, hand washing fixture and storage facility for clean sterile supply material. D. Clean linen storage. A. Soiled workroom, holding room. These must be separate from clean work room and should have separate access door, clinical sink, lavatory, or hand washing fixture for both cold and hot mixing formulas. F. Nourishment station. It should have sink, work counter, refrigerator, storage cabinets and equipment for hot and cold nourishment between scheduled meals. G. An X-ray viewing facility. H. Equipment storage room shall be provided for storage of large items of equipment necessary for patients. I. 24 hours laboratory, radiology and pharmacy services should be available. The following should be provided and may be located outside ICU if conveniently accessible. Visitors waiting room with convenient access to telephones and toilets. 1. Waiting room may serve several critical care units. Adequate office space adjacent to ICU for medical personnel, which should be large enough to permit consulting with members of ICU team and visitors. Staff lounges and toilets with telephones, intercom, and emergency code alarm. Connection with provision person for storage of codes. It should have space for comfortable seating in preparation and consumption of snacks and beverages. A special procedure room if required by functional program. Sleeping and personal care accommodations for staff on 24 hours. On-call work schedule. Multipurpose rooms for staff, patient and patient families for conferences, reports, education training session etc. A housekeeping room containing service sink for flow receptor and provisions for storage of supplies and housekeeping equipment. Storage space for stretchers and wheelchairs in a strategy's location without restricting normal traffic. 4.5.4 Intensive Coronary Care Unit. ICCU, Intensive Coronary Care Unit. Bed numbers may vary from 4 to 8 in small facilities to 20 or more in large centers. These numbers will need to be determined at the service planning stage of the project. The CCU should be in a quiet location that avoids or minimizes disturbing sounds, ambulances, traffic, sirens, disturbing sights, morgue, cemeteries etc. Problems associated with prevailing weather conditions, excessive wind, sun exposure etc. Location should enable expansion, if additional beds are required in the future. Where an open plan arrangement is provided, bed spaces shall be arranged so that there is a clearance of at least 1200 mm from the side of the bed to the nearest fixed obstruction, including bed screens or wall. At the head of the bed, at least 900 mm. Clearance shall be allowed between the bed and any fixed obstruction or wall. Single patient bedrooms including isolation rooms shall have minimum dimensions of 3900 mm by 3900 mm. 4.5.5 Combined medical reception area, patient area, support area, staff and administrative area, education area. The intent of the medical, surgical inpatient unit and intensive care nursing unit design guide is to provide the information and data that will guide planners and facility staff in creating patient environments that achieve the highest quality of patient care on a consistent basis across all facilities. Partitions should generally be gypsum wallboard on appropriately sized metal studs. Use fiberglass reinforced cementitious panels as recommended by manufacturer for wet conditions in lieu of gypsum board as backup. For tile installations in all areas in patient bathrooms. In most spaces, including typical patient rooms, nurse stations, corridors, and supply storage spaces, floors should be a resilient floor tile with a 6-inch, 150 mm high rubber base. Because the floor in a patient room is a large single surface, its color and pattern affect the overall feeling in the room in a significant way. Floor finish choices should strive for warmth and subtle color tones and pattern with which all other finishes in the room can coordinate. Doors should be 1 to 3/4 of an inch, 44 mm thick, solid core, flush wood doors or hollow metal doors in hollow metal frames. Hollow metal doors should be used where high impact is a concern and where fire-rated doors are required. Since wheelchairs and wheeled patient transport should be expected in VA inpatient facilities, and for high traffic areas in general, consider use of doors fully clad in solid vinyl guard sheets. These will maximize protection, add durability, ease maintenance, and lessen an institutional feeling. In non-patient service areas, solid vinyl kick or mop plates should be added to both sides of doors. Door widths of 48 inches, 1050 mm are recommended for all wheel traffic and for extra wide bariatric wheelchairs. 4.5.6 Pediatric Intensive Care Unit provides comprehensive services and care to children with chronic medical and surgical conditions. This facility strives to provide round-the-clock care to critically ill infants, children, and adolescents. PICU should be well equipped with advanced technology and managed by board-certified pediatric intensivists who provide 24/7 in-house specialized emergency care to intensively sick children. Multidisciplinary team provides comprehensive psychological health, physiotherapy, and palliative care. The patient is intensively monitored till the time he is stabilized, especially after major surgeries. 4.5.7 ICU layout. Look at the screen. 4.6 Equipment requirement. As it is well known in the medical practice that in any emergency the determining factor of survival is the time gap between the onset of symptom and the initiation of therapeutic procedure. For these reasons, specially tested stationary equipment having attachment to the walls near each bed are prime requirement of ICU planning. The following equipments and monitoring system are the basic necessity for an intensive care unit. Tracheostomy and intubation set for all age groups, sets for venesection. Instruments for thoracotomy and pleural drainage, trolleys with dressing materials, emergency trolleys. For cardiopulmonary resuscitation, ventilators, central venous pressure recorder, cardioscopes, defibrillators, and pacemakers of perivenous types and emburuban. Resuscitator with face mask, mobile X-ray machines, incubators, oxygen tank and Hypothermia machine with electric thermometers also must be available. Patient monitoring system exhibiting pulse and ECG should be available at each bed. Head. For coronary care area, much more sophisticated patient monitoring is required, which can register arrhythmias and produce both visual and audible signals. The signal should be available at the nurse's desk. In addition to these, physiological recorders for arterial blood pressure and cardiac output measurement by dye dilution technique, by computers and blood volume estimator are preferred. Apart from these, it is also recommended by various authorities that there should be facilities for instant measurement of acid base and oxygen tension in arterial blood by a strapho-electrometric technique and a modified Clock's electrode and be available in adjacent laboratory area where a spirometer test also can be carried out. Although in spite of the ICU being supplied with disposable and CSSD items, it has been felt that a small portable electrically heated pressure steam sterilizer of minimum of 175 mm diameter by 300 mm length for emergency use will be of immense value for its efficiency. 4.7 Policies and Procedures. 4.7.1 Admission Procedure. This system defines those that will benefit most from the ICU, priority 1, to those that will not benefit at all, priority 4, from ICU admission. Priority 1. These are critically ill, unstable patients in need of intensive treatment and monitoring that cannot be provided outside of the ICU. Usually, these treatments include ventilator support, continuous vasoactive drug infusions, etc. Priority 1 patients generally have no limits placed on the extent of therapy they are to receive. Examples of these patients may include post-operative, trauma or acute respiratory failure patients requiring mechanical ventilatory support and hemodynamically unstable patients receiving invasive monitoring and/or vasoactive drugs. Priority 2. These patients require intensive monitoring and may potentially need immediate intervention. No therapeutic limits are generally stipulated for these patients. Examples include patients with chronic comorbid conditions who develop acute severe medical or surgical illness. Priority 3. These unstable patients are critically ill but have a reduced likelihood of recovery because of underlying disease or nature of their acute illness. Priority 3 patients may receive intensive treatment to relieve acute illness but limits on therapeutic efforts may be set, such as no intubation or cardiopulmonary resuscitation. Examples include patients with metastatic malignancy complicated by infection, cardiac tamponade, or airway obstruction. Priority 4. These are patients who are generally not appropriate for ICU admission. Admission of these patients should be on an individual basis, under unusual circumstances and at the discretion of the ICU director. These patients can be placed in the following categories. A. Little or no anticipated benefit from ICU care based on low risk of active intervention that could not safely be administered in a non-ICU setting, too well to benefit from ICU care. Examples include patients with peripheral vascular surgery, hemodynamically stable diabetic ketoacidosis, mild congestive heart failure, conscious drug overdose, etc. B. Patients with terminal and irreversible illness facing imminent death, too sick to benefit from ICU care. For example, severe irreversible brain damage, irreversible multi-organ system failure, metastatic cancer unresponsive to chemotherapy and/or radiation therapy, unless the patient is on a specific treatment protocol. Patients with decision-making capacity who decline intensive care and/or invasive monitoring and who receive comfort care only, brain-dead non-organ donors, patients in a persistent vegetative state, patients who are permanently unconscious, etc. Once the patients are admitted to the ICU, the following policy is recommended. Patients admitted to ICU will remain the clinical responsibility of consultant unit under whom they are admitted. A bed is kept in appropriate ward to await their return. No patients are directly admitted to ICU. However, patients coming directly from causality transfer from other hospitals are first shown admitted under a special unit in ward and then shifted to ICU. Admission to ICU shall normally be on the recommendation of ICU consultant. Admission will be made to ICU only if bed is available or alternative arrangement. For specialized care in intermediate care area will be done. 4.7.2 Day-to-day care. Under whom patient is admitted. The main decision regarding treatment is taken in these rounds. The treatment instituted to patients is written by the senior resident posted in ICU. The decision of discharge of patients is taken in consultation with the consultant of the parent unit under whom the patient was admitted. A simple criterion can be followed. A. Patients who have recovered and are stable can be discharged. B. Patients in whom immediate threat is alleviated but requires close observation can either be discharged to wards or in intermediate care areas, depending on need for one CU bed. C. Patients in whom immediate threat is alleviated but expected to die shortly are observed in ICU depending on bed required for other patients with recoverable illness. D. Patients in whom death is agreed to be imminent, even then if intensive care is continued, depends on availability or resources. 4.7.3 Quality assessment. Care unit is not always obvious. Every unit must develop plan for monitoring and evaluation, quality of care, by whatever definition. The physician's view of quality of trauma cases is in terms of readiness of OT, availability of ICU intensive care nurse and team protocol followed towards successful outcome. The patient's perception of quality is in terms of convenience, a caring staff, availability, or services without undue weight and how he reels at the end of it. The administrators may consider cost and length of patient stay as primary factors in assessing the procedure's quality. The regulator, controller may look at all of above. The 10 steps plan for monitoring and evaluation is as follows. Assigned responsibility. Who is responsible physician in charge of ICU and staff? Delineate scope of key function. What do one look at? Identify important aspects of care. What activities have highest priority? How to know what you're doing is right. Set indicators. When one knows that there is need for improvement. Press triggers for evaluation. What actually needs improvement? Probably methodology, data collection and aggregation. Do not know why it needs improvement. Process of evaluation. Know why, then action after evaluation and feedback. How much successful improvement is measured? Then what? Lastly, documentation and communication. 4.7.4 Aspects of care. The monitoring and evaluation depend on aspects of care being provided in the ICU. And the indicators and triggers to evaluate each procedure is developed. The different aspects of care evaluated in ICU include mortality, morbidity, appropriateness of admission, medication errors, timelines of discharge, assessment of physician response time, performance of tracheotomy care, management of ventilator support patients, performance of hazardous procedure, monitoring effects of medication ordered and administered, assessment of standard orders compared with actual practice, evaluation of patient satisfaction, evaluation of staff complaints and satisfaction, evaluation of nutritional needs, evaluation of patient care incidents, assessment of appropriate use of intravenous lines, assessment of equipment failure, development of CPR protocol. 4.7.5 Outcome monitoring. Primary outcome monitoring. 1. ICU costs. Case costing will be used to determine the costs associated with ICU care during the study period, including I. ICU total costs, E. ICU direct costs, i.e., all expenses to the hospital with fee codes linked to patient chart, E. ICU indirect costs, i.e., any overhead operational fees associated with service provided to patient, IV. ICU cost. 2. ICU quality metric. 1. Ventilator associated pneumonia. This outcome will be included to evaluate the quality of ICU patient care during the study period. The number of patients who develop ventilator associated pneumonia will be collected from the TO data warehouse and Montfort's Department of Archives and Decision Support. 3. ICU quality metric. 2. Central line infections. This outcome will be included to evaluate the quality of ICU patient care during the study period. The number of patients who develop central line infections will be collected from the TO data warehouse and Montfort's Department of Archives and Decision Support. 4. ICU quality metric. 4. early mobilization. This outcome will be included to evaluate the quality of ICU patient care during the study period. The number of patients who receive early mobilization will be collected from the TO data warehouse and Montfort's Department of Archives and Decision Support. Secondary outcome monitoring. 1. ICU patient outcomes. 1. Length of stay metrics for evaluation concerning patient outcomes include measurement of length of stay within the ICU in days or loss. Patient data used for this analysis will be collected from TO data warehouse and Montfort's Department of Archives and Decision Support. 2. ICU patient outcomes. 2. Patient deaths metrics for evaluation concerning patient outcomes include measurement of the number of patients who die within the ICU. Patient data used for this analysis will be collected from TO data warehouse and Montfort's Department of Archives and Decision Support. 3. ICU patient outcomes. 3. Perceived quality of care metrics for evaluation concerning patient outcomes include measurement of the quality of care perceived by patients and their families. 4.8 Cost effectiveness. The important aspect in terms of quality is cost effectiveness. More money spent on prenatal care results in less money spent on neonatal ICU care. Cost effectiveness analysis, SAR, and related techniques are methods for evaluating the economic efficiency of health-related programs and interventions. Treatment of critically ill patients includes expensive equipment, highly skilled personnel, and often costly procedures to save lives. Studies that deal with the outcome of treatment in an intensive care unit, ICU, have reported mortality of critically ill patients between 8% and 33%, with a further 11% to 64% mortality rate on general hospital wards after ICU treatment. Intensive care is an expensive specialty due to its need for highly trained personnel in modern technology and is a low priority for public health authorities in resource-limited countries. Objective analysis of costs and outcomes is needed to determine whether an admission to an ICU is a reasonable use of limited resources in a population of critically ill patients. 4.9 Coordination and control. Care coordination in the primary care practice involves deliberately organizing patient care activities and sharing information among all of the participants concerned with a patient's care to achieve safer and more effective care. The main goal of care coordination is to meet patients' needs and preferences in the delivery of high-quality, high-value health care. This means that the patient's needs and preferences are known and communicated at the right time to the right people, and that this information is used to guide the delivery of safe, appropriate, and effective care. There are two ways of achieving coordinated care, using broad approaches that are commonly used to improve healthcare delivery and using specific care coordination activities. Examples of broad care coordination approaches include teamwork, care management, medication management, health information technology, patient-centered medical home. Well-designed, targeted care coordination that is delivered to the right people can improve outcomes for everyone, patients, providers, and payers. 4.10 Summary. In this unit you have learned that ICU is an area where seriously sick patients, highly skilled staff with the knowledge and experience to treat the patients, use equipment for better results at reduced costs. In ICU there are valuable facilities with high-tech equipments, medicines supporting aspirations of patients, society, and specialists. There was also a discussion about the priorities on which admission of patient is done. You have also learned that it provides a safe, traumatic and humane environment for critically ill patients. In addition, you have also learned about the physical facilities, staffing pattern, coordination and control besides method of quality assessment and appropriateness of care. The relationship among cost, quality and liability are assessed, and a favorable balance of improvement achieved. Thank you for watching. We will see you in the next video with the next chapter.